So, hello everyone. Super excited for today's episode. So, today we'll be having Dr. Ethan Sims onto the podcast. Is now in Boise, Idaho. So, he recently left his position as the medical director for sustainability at St. Luke's Hospital there, but he has been an ER doc since 2017 and is now just focusing on that position. Additionally, he has a nonprofit that is called the Idaho Clinicians for Climate and Health. So all in all, lots of things that we have to discuss. I was really intrigued though when I saw you on the EJ Mentor platform because you were one of my 3 matches. And very interested to see that you are also an interdisciplinary studies major because it's so rare here. I know one person that's interdisciplinary studies. So just want to know more about that, like how you found the major, what your focus area was, like if you had a curriculum copy or something like that could be cool to look at as well.
Yeah, I found out about the major through my advisors, a guy named Carl Espley, who I don't think is still there, but he was an advisor for a ton of honor students and foundation fellow students. And, I knew I wanted to go into medicine, but I didn't necessarily want to do like a ton of chemistry or biochemistry or I wanted to really more kind of explore medicine, and there wasn't a major that really fit that niche. So we looked at some things like anthropology and history that could add some background and kind of really give me a pre-medical studies degree, which wasn't an opportunity then. And so I took a bunch of non-science classes like anthropology and history of medicine. And I think it really prepared me well for my career in medicine and, gave me a lot of depth into kind of how medicine has gotten to where it is today. And, I think if you don't know the history, you'll repeat the mistakes in the future. So it's good to look at things like that. And anthropology is really useful in studying systematic illness. And now that I've kind of branched into some public health roles with this climate change work that I'm doing, I think knowing a bit more anthropological background towards how medicine has evolved has really helped me where I am now. Much more so than another high-level chemistry class would have.
Yeah, I would definitely agree. There are a few anthropology courses in my curriculum actually. It's posted on my LinkedIn if you want to look at the document under education. But I am taking multicultural healthcare. That's an anthropology one. Did you take that?
No, I actually did a semester exchange at the University of Utah and took anthropology of medicine there. And it was an awesome class. And the teacher that taught it became someone who wrote a letter of recommendation for me, somebody that I stayed in touch with after college. I've lost touch with her now, but that was a really meaningful, impactful class for me.
That's cool. What about biological anthropology?
Did not take any classes in that.
They're okay, because that counts for one of my gen ed sciences, so I think I'm gonna take that. But it seems really interesting.
Yeah, my brother-in-law is a philosophy professor, and what's interesting is that he is really interested in the history of medicine and how medical experimentation happened, and I never thought of like philosophy touching on stuff like that, but it is talking with him has opened my eyes a lot to kind of the philosophical, historical application of scientific technique and like the ethics associated with it. I think that that anthropology of biology would be a really cool class.
For sure. That definitely sounds really interesting. I think also like yeah, the philosophy overall with medicine is interesting, but then especially uh, when I've read books about like grief, dying, loss, bereavement, all those topics, and like end of life care and uh, you know different states having different laws on like assisted deaths and stuff. So that's definitely a really interesting area, but like also super controversial because everyone has different opinions on like the morality surrounding that aspect of end of life care.
Yeah. But what's interesting is like once you get in and practice medicine for a while, I think the more exposure you have to end of life care, the more supportive you are of things like that. And I don't know anyone who's practiced medicine for a long time that doesn't have what we call a post form expressing their wishes about how they'd want to be cared for. Uh, because like a lot of the stuff we do at the end of life is not just unlikely to be successful in bringing someone back to a meaningful state, but it's also uncomfortable and feels cruel and unusual when you're doing it. So um, yeah, I think most people in medicine that have seen enough death realize that we probably do too much at the end of life.
Yeah,
Not probably. We definitely do too much at the end of life.
think there's some statistic where like most of the money that we spend on healthcare it is allocated towards like a very small percentage of people, especially like at the end of their life. So definitely adds up there. So did you ever like have a name for your interdisciplinary studies major or
Yeah,
any?
I think it was like biology with a focus on pre-medical studies, but let me see if I can find it for sure.
I just got my major approved like maybe like 4 days ago. So that was super exciting. But um,
Did you work with your advisor a lot on it? I mean,
not
like
really.
my advisor was awesome, and I think that's another thing that I realize in going through college, like things that make your college experience so much more fruitful are having people that are supportive of you. Yeah,
Yeah. Our advisor was great, but um, it was maybe like the interdisciplinary studies program kind of shifted with the new advisor, like just how it works. But it was more so like, here's the packet, find some professors to like help you build this out. But if there's any like technical questions about applying, like I'm here. So it's more so like that. But I think it's a really fun experience. Like well, I call interdisciplinary studies IDS, by the way, just for shorthand. But I mean, you get a ton of creativity, and it's like really cool to be able to partner with professors and like, especially you get the ones that are like super passionate about what they study, and then they see your passion, and then they're willing to like, they're not getting paid extra for it, but you know, it it really does like fill their cup and excite them.
yeah. I
So
mean, everybody wants to work with people that have genuine interest, and so like the more enthusiastic you are about your taking control of your educational path, I think the more likely you are to get that positive feedback and engagement from faculty. So Faculty want to see interested, engaged, excited students who, are like, hey, this isn't fitting what I want. I need to do something different. And I think that was sort of how my HIS experience was, or interdisciplinary studies was, um, where it was like, I had an advisor who knew me well, who knew what I wanted to do, and saw that most of the majors I was trying to fit myself into didn't really, fulfill what I wanted to get out of my experience. And I mean, the reality is, you're going to college, you're paying a lot of money, or you've got a nice scholarship to pay for you to go to college, and you're the client of the school, um, right? So the school should be working for you. My oldest daughter is starting school right now, or just graduated high school and is going into her freshman year, and she's like, well, I only have 4 classes this semester, and I've got like 12 options for what I might want to do. And these are ones I don't really want to. It's like, no, 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 no. Like, you should be like advocating for yourself and directing what you want to do. You're paying a lot of money to go to school. Like, get what you want out of it. And if you don't know, like, the school has a bunch of resources to help you figure out how you can maximize your experience there. And, colleges want you to do that, because then you're going to come out a better student, a better job applicant. You're going to have a more successful career, and reflect better on the experience that the University of Georgia gave you. So I think it behooves the university to support students in programs like this.
Yeah, I definitely agree. I mean, even though I have Zelt, I mean, there's tons of like living costs, and then, just the amount of time you're putting in. And it's like,
Mhm.
you're reaching like the end of your freshman year, and you're just like, I've tried a bunch of majors. This doesn't fit. IDS was always like basically the last resort I had thought of, like the summer before college. I was like, if I don't like anything else, I can always make an option. But it seems kind of hard. So I'm going to try out some other stuff first. But I think it was also because I was just fluctuating between a lot of different academic and professional goals, like came in kind of like pre-health, uh, wanted to be like an anesthesiologist assistant. And then I was like, I don't really like these like science classes. These are kind of soul sucking. And then I was pre-business for a bit, but then, was just kind of like, eh. But and then come January, I think I went to the career center actually. I had an appointment with them. And then they had some inventories. They have 3, but there's one like the strong interest inventory. Like that one's super thorough. You get like a 17-page report out of it.
Whew.
So lots of data to work with, and then you can only look at that data if you book an appointment with one of their career consultants. So then like Well kept popping up on all those and various legal professions, and I was like, I hadn't really thought about it before that, but then I was like, I mean, I guess let me investigate this, because I never really considered myself like, oh, like I want to be a lawyer. I want to, be in the courtroom. Like that always seemed like super intimidating and stuff. But there's a lot of other things you can also do with a JD,
Oh,
in
for
hindsight.
sure. Yeah, I mean,
So
I know a ton of people that have law degrees, and I know very few people that are in courtrooms. So the
yeah,
vast majority of people that get a legal degree end up doing, either some kind of business law where they're never doing litigation, or being a consultant and, um, offering legal advice to different organizations or companies. But the vast majority of people that get a law degree that I know, and I would presume that's reflective of the law school as a whole, um, aren't doing a lot of, you know, litigation in the courtroom.
yeah. Um, I mean, I might have to be a lawyer for a few years just to like get that experience, and then think I'd enjoy being a law professor more. I'm kind of invested in my research. I think um, the blog and the podcast is kind of a reflection of that. And then, like working with students, I think would be a lot of fun. Um, and then I think the work-life balance would also be better. So that's appealing. But I did actually find this one role because, like, funnily enough, on that inventory, like the number one career match was like magistrate judge. And I was like, I've never heard of that. But then I looked into it and like, okay, seems interesting. But then I think actually the other week I was trying to find something if there was something closer to it that involved healthcare. And then the HHS actually has admin law judges, but like it's not a courtroom. It's like typically it's done over video conferencing because there's only like 10 districts for the HHS. And then if it is in person, it's in like a conference room. It's more so about like specifics of Medicare, Medicaid kind of rules. But I was like, see, like that seems a lot more chill. And I feel like you could also be younger and do it. So, but that's still something like for my 40s, probably. So, just,
You got time.
yeah, exactly. I have 20 years to prepare my resume.
Yeah. The end of college, you just need to figure out where your next step is going to be. It's good if you can have a vision for where the road is going to lead you, so you can make sure you're taking the steps to get you there. But a lot of this step is figuring out what the next step is, and whether that's law school, grad school, med school, just figuring out where you want to go with your life, jumping into a job right away, taking time off, travel, like college has got to prepare you for knowing what that next step is.
Yeah, it definitely has been a really incredible experience at UGA though. That's why like I would love to stay at UGA for future degrees, but I don't know. I think I used to be like more confident about wanting an MHA, and then now I'm like, I don't know if I need that for what I want to do. I don't know. It still seems pretty interesting, and I feel like that could still weave into my research. Knowing how health admin works, but we'll see. I have until like maybe August or September to like figure out when I'm graduating or like if I need to apply in the fall to grad school. So we're doing good.
I love the half gap year idea. I love it.
Yeah, no, I feel it's been growing on me. I think because I think earlier this summer I was like, oh, I always do this like every college summer. I'm like, what am I gonna do all summer? Like I'm so used to be busy. Like, I'm gonna be like bored out of my mind. I'm not gonna like it. And then it's like, no, you find things to do. You pick up hobbies. You rest. That's important too. Like, and like I'm like starting to like really enjoy that now too. Now that a ton of the blog articles are up and I feel like I don't really have any plans. So just like kind of hanging out. That's why I came back to Athens actually like yesterday. I was like, I'm gonna come back, use my apartment's amenities, check out the pool, hot tub, sauna situation, have like a fun pool day with a friend, do an Atlanta day trip the following day, see some people, and then go back to Dalton and then just like rot away in my room. So, and so rest is definitely really important. I think, like, okay, and I would have loved to like do like a full gap year too, but there's just not a lot of positions really, or like internships in kind of like healthcare law that are year round. Like everything, there's like very few, and the ones that are there are just like summer only. So, but I think still like January through August, that's like still a great chunk of time to like chill. So I think that should be enough.
Yeah.
So did you know any other like interdisciplinary studies majors when you were in undergrad? Was it like how it is now, which is like, oh, what's that? I've never heard of that. That's a thing here?
Yeah, sort of. I mean, I didn't know anyone else who did it. and I just described it as a choose your own adventure major. And I think people kind of got the gist of it. And I think a lot of people, when I described it, were like, "Ooh, that would have been awesome. Why didn't I do that?" Um, and I think the university makes it challenging to do it because they don't want people, skipping out on hard classes within a major or building something just because they don't want to do things that are challenging, or like set up some really fluff degree that's not going to get people anywhere. And the university has built majors the way they have because they think it's going to prepare you best for the next step in X, Y, or Z. But like you had said, it just doesn't. Not everybody fits in one of those boxes. And I think the more um, sort of engaged you are and determined you are to get a specific experience out of college, the more the interdisciplinary studies major is a fit for you because um, like you to get the most out of it, you really have to care about what you're taking. And I think if you just want to get through school, get a degree, and move on to the next step, then doing a general major that's already in existence is pretty easy. But it just didn't work for me, and I wanted to get more out of college than just a biology major or something. So I think I was a microbiology major before I switched, and it's like I like microbiome, but I don't know that I want to take a ton of more microbiome classes when I know, like in medicine, it's not really what I'm going to need. Like, most of college classes are not directly applicable to my career as a physician. Uh, and like I'd say anthropology and history probably were more um, helpful to me in my actual day-to-day work than biochem and certainly OChem. Ugh.
Yeah. They actually, I think they made chemistry recitation. Like I think they took that off now, starting this fall. So that's a win because everyone kept complaining about it. Um, but there are two other anthropology courses. If they are offered, I do have space to take them. So I was wondering if you had taken ancient human health or health, biology, and culture.
I don't remember that either of those topics were around when I was around.
Yeah, I mean, there's a
It
ton of like,
has been a long time since I've been in college. I am old.
that's fair. Um, but I think like the thing I most liked about IDS is like, oh, you can just get waivers for pre and co-regs and then just take a bunch of cool upper division classes. So that was really fun. I think last semester, 5 out of my 6 classes were just by doing that. So I was in Terry doing foundations of AI in business, and then human development and family science. I was doing pediatric pain. That was like run by a child life specialist. So that was fun. And then adolescent neurodevelopment, sociology of healthcare, and I forgot. Let's see. But yeah, that was really fun. But I think anyone that's intending on grad school, like this is really the perfect major. If you're willing to like actually grind it out a little bit. I think like my approach to it was kind of intense. I don't think it's supposed to be this hard. I don't think you have to make like a 16-page curriculum and do like 18 specializations and all this for a class.
I definitely didn't.
And like, okay, the major's called Health Tech Law and Regulation. There's only like 2 actual healthcare law related classes. So it's like we're just finding stuff from all over the place and like building it up. But like it was really fun. But I was thinking about this fall, like what if I table at Tate and I just have like a poster with that says like new healthcare major and then like try to get pre-health people to do it, because there's only like one required healthcare wall class. It's just intro to health policy, and then the rest, it's mostly just healthcare related stuff, and like they have a ton of flexibility for all their required courses for grad school. So what do you think? Do you think people would like do it, or if it's
I
really
mean, it's a pretty niche degree that you're creating, and but it's a very needed area. And I think we would do a lot better if we had reform of healthcare policy. And it's hard when uh, like you get out in the real world and you practice medicine. It's hard to step away from your clinical practice and try to pivot to things like policy, because it's so daunting mid-career to switch into something that's very different from the day-to-day practice of medicine. And I think where a lot of medical issues fall apart is that there's not enough input from people that have that experience, um, to, if you have administrators that have never practiced medicine that are making all the decisions about healthcare policy, um, then it's really hard to get things right. Because if you're not walking in the halls of the hospital or the clinic, you don't really know how things work. So I think having a bunch of exposure to healthcare and knowing that you're using that to develop a career in law or policy, is a really cool idea for how to set yourself up to be good at your job, not just in a job.
there is also a course requirement for sociology of healthcare, which would definitely work for them. But then there's one that it has to relate to artificial intelligence. I don't know if pre-health people would be into that. I'm not sure. So,
I mean, AI is gonna change medical practice in a lot of ways, and we're already starting to see some of the things. Most of what I see is AI, being offered as a way to dictate your notes, and just do your charting for you. But people like radiologists are seeing that AI is being used to help triage their imaging studies. So, AI will interpret the images and not give definitive reads, but tell a radiologist this scan looks abnormal. Look at this one first. Um, and it's being used for measurements of certain abnormalities like bleeding inside the brain. It can give you a specific volume that previously radiologists were calculating based on just lines they're drawing, but now AI is just telling you. And then things like reading EKGs, AI is being used in some studies to basically do the same thing for us that it does for radiologists, not to tell you what exactly it is, but to tell you which ones you should pay more attention to. Like kind of put a red flag on certain patterns. That's really what a lot of medicine is pattern recognition. And I think it's helpful if AI can do that. But as a clinician who's worried about environmental impacts and how the environment is driving health impacts, AI is hugely energy intensive. And I think the yield we get out of using AI is pretty low at the moment. And the costs to the environment of all that water and power that the data centers are using to uh, create these AI platforms is probably a net negative at the moment. It doesn't mean that in the future it won't be worth it, or that we couldn't build these things in a way that they were, more responsible, using recycled water and really never taking more water out of the system than they're using, or using solar power so that they're not using the electric grid and depleting people of access to electricity, or using coal and things that are burning fossil fuels to generate the power that it takes to create AI. So there's a lot to think about when you're thinking about the overall utility of AI in human health. is it good at what it's doing? And is the cost of how you get there worth it in terms of its impact on the environment we live in?
Yeah, they're actually building over 200 acres of data centers near where I live.
Oof.
So,
Use your
yeah,
voice. Use your voice. Talk to them about why that's a bad idea. Because like, so you think of things. I don't remember Georgia having this issue, but out west we have this a lot with rolling blackouts, where the energy grid is strained, and because that strain is so high, there's a risk of failure. Or there, like for me, there's a wildfire that's impeding on the grid, and so they have to shut the grid down, um, and then people lose access to power. And if you have a enormous data center that's using a ton more power than the grid is actually able to produce, then that's going to make the risk of people losing their heating or air conditioning, losing the risk of their access to electricity at their home much higher. And for what? For a private company to use a ton more energy? I'm not sure that's a fair situation. Um, and like the other thing that people don't consider with AI is not just the power, but the water, because there are huge water rights needs for these data centers. Places like Utah are seeing big issues with that now, where there's a data center being built in Northwest Utah that's going to use more power than the rest of the state combined, and more water than the rest of the state combined. But there's not more power being generated. There's not more water flowing into the state. So what's going to happen to the rest of the state when this data center gets built?
that's where. How many acres is the data center? Let's find out.
So it's more than twice the size of Manhattan, 40,000 acres.
Oh my gosh, it's insane.
Yeah. And
So,
of course, it was like a sweetheart deal between a politician and the guy who owns the company, who, of course, is not from Utah. So won't be impacted by it on its own. I'm going to put up a little article here for you about it.
oh, nice. I'll have to check that out later.
It's a really big deal here, because Salt Lake is having so many issues with drought, that are really impacting air quality in the city. Salt Lake's really windy, and as the Great Salt Lake evaporates and dries up, um, they're getting all this toxic dust from the lake bed blowing into Salt Lake City. Um, and the biggest risk of that is taking water, and using it for something else like irrigation, or a data center like this. And then it like disturbs the water cycle, so they don't get as much lake effect snow. And snow is a huge deal to Salt Lake because so much of their winter business is around skiing. And they had a really terrible year last year, which made it so that the ski resorts weren't open for long periods of time, which means a ton of lost revenue and jobs. In addition to the like acute health issues that are coming out of something like this happening. Water is a huge issue, and it's gonna become more of an issue over time. So, like legal issues around water rights would be a really cool area to investigate if you're looking for something that's sort of not that discussed now, but going to be discussed a lot when you're out in the real world.
Yeah, I'll definitely have to look into it more. I didn't realize that these centers to cool the computers, like they have to use water, like massive amounts of water to do it. I know they're trying to make like I think Microsoft's trying to make like a more efficient way that doesn't use as much water, but to think like this is industry standard, I mean, it's crazy.
Yeah, I mean, before we lived in Idaho, we lived in New Mexico, which also desert, Mountain West. Rio Grande is drying up, and the biggest employer outside of the government and healthcare was Intel, which is a chip manufacturer. which uses a ton of water. And now here in Idaho, Micron is the next biggest employer besides government and healthcare. And Micron uses a ton of water. And they're actually building like 4 new fabrication buildings that are going to use a ton of water. And they sit upstream of the city of Boise. So they're taking water out of the aqueduct or the river and using it before the city has access to it. They're doing a lot, and I know their director of sustainability, and she's trying to make it so that they're water neutral. Like they take an amount of water in, and then they just clean and recycle it over and over and over and over again. But that's not true for all of these fabrication buildings. And like the fab buildings are enormous. They're like the size of a football field each, and they're building 4 of them concurrently right now. It's insane.
Right. Oh, I was looking up what fabrication buildings are.
It's where they actually are making the chips. So like
Oh,
the production plants. Like Micron's campus, just like Intel's in New Mexico, it's like, it is enormous. Like it's such a huge physical footprint because they have people on site doing research and development, doing, you know, like the business of the company. But then they also like actually build the chips, package them and ship them there. So it's just kind of everything is housed in this one enormous area and then divided up into a million different specialty areas. But because they're, you know, doing so well, they need to build more chips. So they need more fab buildings to do it. And so they're building a bunch in New York. They're building a bunch here.
interesting. So, how was your experience as being the medical director of sustainability at your hospital, and how did you find this role? Because I know priorly you were a medical school professor in New Mexico.
Yeah, so I mean, I was faculty at UNM, but really in the sense that I was an ER attending at an academic hospital. I taught one class, but for the most part, I was like doing clinical instruction. Um, and you know, in that role, I had to do some research and I had to do some teaching and education outside of clinical responsibilities. Um, but when I came here, I was just doing clinical work and I missed a lot of the, you know, working with students because we don't have a med school in Boise and we don't have a ton of students that rotate with us or residency programs that you can work with learners. So I've tried to find some other ways to stay engaged because I think if you aren't kind of, if you're just kind of settled and doing the same thing over and over again, like you get lazy and bored and get bad at your job. So I think you got to keep, you know, it's the growth mindset thing. You got to have a growth mindset. If you don't, you get static, and static is the way to get left behind. So um, I saw a problem in our community where, you know, every year that we've lived here, it's gotten hotter. Every year that we've lived here, the wildfires have been bigger and worse. Every year that we've lived here, the droughts have gotten worse. And, you know, I hadn't really thought about how healthcare played a role in that. But if you look at it, healthcare is responsible for somewhere between 7 and 10% of the US's greenhouse gas emissions. So it's a big opportunity to reduce the thing that's driving climate change, which is ultimately driving a lot of human health problems. So I'm trying to approach it as climate change is a health issue, not a political issue. And so I started a nonprofit first called the Idaho Clinicians for Climate and Health that is really trying to work on educating the community that we serve and educating the community of clinicians that we work with how climate change is impacting human health. and then also looking at how you practice in your job and how that impacts climate change. Um, and, I got really excited and interested in sustainability in healthcare because, like, I recycle at home. That doesn't really do much. I try to be conscious about energy conservation at home. It's a teeny tiny drop in the bucket. But if I could get the largest employer in the state of Idaho to care more about waste reduction and energy waste reduction, like I could actually make a bigger difference. Um, and the hospital had started a sustainability program with an engineer and some building energy managers and waste management. Um, and I started kind of volunteering with them for a while. And then I was like doing so much work with them that I felt like we needed to have a position that I could get paid for the time that I was giving them. So I met with some of the hospital leadership and proposed this position, which they then created. And then I had to apply for the job and got it. Um, and I think it was really, so I've stopped doing it because while it has a lot of reward, it also comes with a lot of frustration. And I feel like our healthcare system ultimately wasn't really ready to make the changes that we needed to make. Um, so I just didn't feel like I had enough institutional support to accomplish what I wanted to accomplish. And that just led to a lot of frustration. I was going to meetings over and over and over again and spending like all of my free time doing meetings that led to nothing happening. Um, so I was like, look, my kids are a junior and senior in high school. I'm going to go spend time with them and not spend time doing this. So I stepped away from the role in January and have focused more on the nonprofit side of things, where I control, what I want to get done, and I'm not getting paid, so I can just, do whatever I want to do, uh, and trying to grow the nonprofit side of things. So I'm mostly working on the Idaho Clinicians for Climate and Health now, but still, friendly with the people on sustainability, and get approached at work all the time about sustainable ideas, and how can I do X, Y, and Z.
So, how has been growing that nonprofit been? And, you know, on the EJ Mentor platform, I think it said that you're board VP.
So now I'm the executive director. So when I left that job, our executive director was having a second kid and she wanted to get out of that position. So I came back and took over the executive director position and stepped away from the board. So now I'm the executive director.
Awesome. But yeah, how has been growing that been? And then, growing that community to like how many people now that like regularly stay involved in the org, and like what are some big issues for you guys, or like events y'all have had, and like big milestones you guys have accomplished as well?
Yeah, so we put on a monthly climate and health learning series, which we have more than 2,000 people registered for now. And we usually have about 200 people in attendance at most of our lectures. And then we post them all on YouTube and usually get about another 250 to 500 views on YouTube after the fact. And that is a lot of my work right now, is developing and moderating that climate and health learning series. We put on a sustainability in healthcare symposium once a year, and that's coming up in September, on September 2nd. And so that's a full day event, sort of educating people about climate change and health impacts, as well as like this year, we're really focusing on heat, smoke, and drought, and talking about the medical issues associated with them, and then community-based strategies to reduce the risks of those things, both in like how you practice medicine, but also how you engage with the community. Um, and I work with the city on a heat safety initiative. So I'm working with the city to develop a heat safety strategy as the summers get hotter and hotter here, and trying to identify vulnerable populations that are being impacted by it, trying to identify like the actual health impacts that we've already seen. We put on a film festival once a year. That last year we focused on snow loss because the ski resorts here didn't really open. And usually we open in like end of November, and they didn't open until like mid-January this year because we just didn't have any snow. So we had a film festival that focused on why the earth is changing and why we're not getting as much snow as we used to try to, again, this is not like there are several communities in Idaho that are like Utah and that they really rely, like Sun Valley is built around the fact that they have a great ski resort and it's a very high-end community. But if they didn't have a ski resort, like nobody really would go there. And there are projections that show that areas with elevation like Sun Valley are going to start having little to no snow as soon as 2035. So what is that community going to do to adapt to an environment where they're not getting snow? And how are they going to, maintain their viability economically if they lose all the jobs and revenue that's associated with tourism and the ski industry? Because that's going to have downstream health impacts, right? So I've learned a lot that the language that the people who make decisions speak is all financial, and the language that passionate advocates speak is not something that financial leaders hear. So, I can get on a soapbox and beg and plead and talk about the extinction of animals and like loss of places that I love, and people just don't jive with that when you're talking to like a healthcare administrator. But when you talk about how like we're already at capacity in most of our hospitals all the time, and these extreme heat events like essentially bring in, a third more patients every time we have a severe heat event, or when there's a wildfire smoke, we get like an extra 20 patients a day. And where are we going to put those patients? How are we going to staff the hospitals for them? Then healthcare executives start listening to it, like, oh, this is a problem that's going to impact our operations. Or when you talk to them about how they can be more sustainable in their practice, they don't really want to hear that it's going to reduce your carbon emissions because they're not being tracked on carbon emissions yet. But when you say, hey, this is going to save you a bunch of money, and they're like, ooh, I like that. We could use more money. So, and it's like the foundations of sustainability are really about efficiency in operations, which I think is an issue that crosses all party lines and, should be something that everybody wants. I bet your dad chased you around the house and was always nagging you to turn off the lights after you left the room. We have a lot of rooms in all of our hospitals and clinic buildings that people leave the lights on, and people leave computers on, and people leave the air conditioning set at way colder than it needs to be when the building's unoccupied. And if you just focus on changing those things, having setbacks for your air conditioning turning down in the evening when no one's occupying the building, having all the lights and computers automatically shut down, like you can save a ton of money, and also reduce your carbon footprint because you're not burning all that energy for nothing. And it's like simple, common sense ideas like that that you build some wins and build some successes and start to show people like, hey, this actually is like good for your business. And after you've done that and fostered some goodwill, then you can start to lean into, hey, we should look at getting solar on the clinic spaces because like it could really save you a lot of money. And you've proven that you can bring some savings to a company, and then they're more willing to listen to you when you have ideas they're less comfortable with.
That's definitely very fair that they tend to be focused on the monetary side of things. I actually brought this up in one of my blog articles that was about making accessible UI UX design. And in one of the books relating to the subject that I read, that was with like an accessible UI UX expert, he was like, you know, if you really want to get people at the company's attention, you have to, you know, bring up words like liability and revenue. Otherwise, like if you're just being like, well, it's the right thing to do to make sure that, you know, our website or so and so company's products are more accessible to people, it's like they don't really care that much, which is sad.
Yeah, I mean, I think you're right. It's risk and finance. Those are the two things you have to hit on to get leaders' attention, because they don't want to get in trouble and they don't want to lose money. They don't want to like not be able to operate. And I mean, I think the burden on healthcare executives is very high, because if the hospital CEO at St. Luke's, which is the largest healthcare provider in the state of Idaho, messes up our finances and we can't continue to operate, like that's all those other people, they can't get healthcare. So it's a huge responsibility on your shoulders to operate the system in a way that allows you to continue your operations. And so they don't want to hear like, you know, a bunch of pie in the sky ideas that are going to cost a lot of money. They want to hear practical, low risk, high yield solutions.
That's very fair. So going back to your education, so you started out at UGA, then went to Emory Medical right after graduating, and then you moved out west to New Mexico, and then now is it Boise?
Mhm.
Or yeah. My roommate was like correcting me earlier when I was like talking to her, and she was like, "It's not boys. Don't say that." But how did you find yourself moving out so far, and you know, how did it come about that like these two states were like where you chose to go?
So, you know, in medical education, you don't always get to pick where you end up. So you apply for med school and you get in where you get in. You apply to residency after that, and they do this, you know, blind ranked match list that you find out on like a day in March where you're going to go for your residency based on who they liked and who you liked, and the computer matches everybody up. So I went to Chicago for most of my residency training. And my wife had gone to New Mexico for her residency training. And she came up to Chicago when she finished with hers. And then she wanted to go back to New Mexico when I finished with mine. And so we went back to New Mexico. Um, and I was familiar with the ER program there. I knew a bunch of people in it. There was a guy from Emory who I found there that I was friends with. And so we stayed in touch. And, you know, like you get out to the West Coast and it's really hard to leave the West Coast because it's beautiful mountains. Like New Mexico's sunny 300 days a year. Um, there's no humidity. There's not really bugs, like no mosquitoes, no no-see-ums, no ticks, no chiggers. Like it's nice to be out west and be able to go explore the outdoors in a really nice climate. And so we looked, when we were leaving New Mexico, we looked at a lot of different places, but just didn't want to leave the Mountain West because the quality of life is so nice. The environment is so nice out here. Um, and we had a bunch of friends that had moved to Boise from New Mexico. And it really kind of ticked all the boxes for what we wanted. Good schools for the kids, same kind of, you know, dry, sunny environment, mountains right out the back door. Um, and so it was a pretty easy decision.
That's awesome. So did you grow up in Georgia?
No, I was born in Georgia, but I moved away when I was like 6 months old. And my dad got his PhD at Michigan State. So I was there for 3 years when I was little, and then we moved to Delaware. And I spent, you know, the rest of my childhood in Delaware. But the whole time I knew I wanted to go to UGA, and I don't think I applied to any other colleges. I looked at a few other places and was like, nah.
Why is that?
Both my parents were at Georgia. My aunt and uncle lived in Athens, and so we went and visited a bunch. And I just loved Athens as a place. I love the idea of the University of Georgia. I'm an extrovert. I liked being at a big school. Um, and the honors program gave you a way to be at a big school, but small classes. You still have some entry level classes that are huge. But like you mentioned, you can get into a situation where you're in higher level classes that have a great student to faculty ratio. And you're having discussion based classes about high level science stuff. And it was just kind of offered everything I wanted.
It's fair. I actually was curious about your experience in the honors program as well.
Yeah, I loved it. I lived in Myers, the honors dorm. I don't know if it's still the honors dorm. But when I was there, it didn't have air conditioning, so it was like, oh. Um, but I lived in the honors dorm for 2 years. Met a bunch of people in honors programs across different areas of studies, um, and I just thought it was such a great experience to be at a big school with all the things Georgia has going on all the time. Um, but then when I went to class, I had like awesome teachers and small class settings. So I think an honors program at a big school to me is like the way to go.
That's
That being
awesome.
said, my daughters are both looking at small schools, so
Yeah.
lame.
Also, with moving out west, like, how have you seen the culture and lifestyle differences between like Georgia, Delaware, New Mexico, Idaho, Chicago?
Yeah, I mean, I think I think there's things like urban versus rural environments. I mean, I live in a small city, but it's certainly not anything like Chicago or Atlanta in terms of the way you live in Boise. So that is probably the biggest differentiator, followed by like the politics of a place like Idaho versus the politics of all those other places. Georgia is certainly still conservative, but it's become quite purple. And New Mexico was purple when we got there and became very blue over the time of our living there. But Idaho is deep red and only getting redder. And I am not a conservative person. So I think living in different political environments where there, is a lot of stuff that you uh, feel intrudes on your life a bit. I feel like the conservative parties have always prided themselves on parties of freedom, but I have felt much more constrained both in my clinical practice with things like women's health restrictions, which Idaho has some of the most restrictive in the country. And as an emergency physician, I see issues associated with that all the time. I've seen a bunch of colleagues in OB and family practice that deal with labor and delivery leave the state because of the risks associated with practicing obstetrics in the state. Um, I've seen my kids have issues at school where uh, books are being banned, libraries are being shut down because they're not following the book bans to the state the way they're supposed to be done. And it's just hard in that sense um, to see why people live this way, especially when you've been in other places that are uh, really more truly liberal and open to different ideas and letting people live the way they want to live.
No, I actually just did a bit of research about Idaho's like abortion, like book bans that you were mentioning, and um, I had no idea it was this rigid. Um, so yeah, it being abortion in Idaho is illegal from fertilization, and then this was taken into effect August 2022. So I think this would be, do you know if this is the most intense one in the country, or if other states also have similar ones, or just in general, like with women's health laws?
Yeah, I think there are places like Texas that are pretty similar. They're all sort of bills that are copies of each other. Um, but Idaho has some especially punitive things like Oregon and Washington, which are neighbors, still have access to abortion. Um, and so they have modified the law so that if an adult takes a minor out of state to have an abortion, they can be jailed, which I think is just extra crazy. And they tried to, the Idaho Attorney General was at the Supreme Court arguing against protection of the EMTALA law with pregnant patients in the state of Idaho. So the EMTALA is the act that gives everyone right to emergency care. That says that anyone who seeks care in an ER has to have a medical screening exam and has to be stabilized before they can be released from the hospital, regardless of their ability to pay or any other issues. And they were saying that didn't apply to situations that would require a mother to have an abortion, like an incomplete miscarriage where the baby still has a heartbeat, but the mother's life is potentially at risk because she's bleeding. They ultimately came to an agreement where they carved out ability for our hospital system, because our hospital system's leadership fought against this so hard, to be able to deal with emergent OB care like that. But it's not something that's universally applicable across the state. And again, it just comes down to like people making laws that don't have any knowledge of what they're legislating. So people just like, and you hear like the state legislature discussing bills like this, and you're just like, you have no idea what you're talking about. Like, you just don't know like what. So it's really hard, because like we can face serious repercussions like jail time for doing something that we think is right for our patients. Um, and the thing that's even crazier about a lot of this is that it is not like, I think it was designed to, or they thought it was going to stop elective abortions. Um, and it has impacted desired pregnancies that are being lost with the mother at risk for her health or for the baby's health tremendously. And now the downstream consequences of that being that we've lost a ton of OB care, and labor and delivery units in several hospitals in the state have closed, meaning that patients have to drive like 3 hours now to get OB care. Like those weren't considered in the legislators' minds when they were making these laws. And now their heels are so dug in because they're so proud of how restrictive their law is that they're not willing to amend it to make it so that it is just reaching their initial desired intent. And like you're just being stubborn because you want to look cool on the national stage and be like, that's the most restrictive bill in the nation.
So, can you speak more to how those OB units were closed down?
Yeah, they just lost their providers. So they didn't have any providers. So the first hospital that closed its OB unit was in Sandpoint, Idaho, which is way up north. And they had a small number of obstetricians, and they kind of got together and said, look, we're like 3 hours from the Washington border, where we're not going to be thrown in jail if we practice OB care that we think is appropriate. So people just left and moved to a state that didn't have these laws, where they weren't at risk of having stuff happen that was punishing them with potential jail time for practicing the way they thought was appropriate. And so once you don't have anyone who can provide the service, and they couldn't hire anybody because nobody who's training in OB would go into that environment, then like you just can't run an OB and a labor and delivery unit. And so that was the first hospital, and two other hospitals have closed their OB units for the same reason. They were small. They didn't have that many OB providers to begin with, and their OB providers left because they didn't feel safe practicing in the state. We've lost like a quarter of the OB providers in the state of Idaho since the law went into effect. And Idaho has like the worst physician to patient ratio in the nation for most specialties. So we started with bad numbers, and now they've gotten worse.
Essentially. Yeah, I mean, that makes sense that, of course, like labor and delivery units, I feel like most of the time they're not going to run into situations where they could, as a result of like what they think of doing what they think is right, like, facing possible jail time, but there's still that risk for, you just don't know what kind of situations can walk into. And then, a lot of times laws, you can kind of work in the blurry lines. So it can definitely feel risky.
Yeah. And I mean, there are people that have approached it by saying, I want to get sued because I want to show how stupid this is, or I want to get in trouble with this. But like most people are like, I just want to do my job. I just want to take care of patients. And again, these are not ever situations where you're dealing with an elective abortion. These are situations where you're dealing with desired pregnancies with complications. So again, that whole political issue of whether you think an elective abortion is okay or not is not the issue that's driving all of these problems.
That's fair. So I was doing a bit of research about St. Luke's, and it seems like they are a bit of a leader when it comes to hospital sustainability and social responsibility. I know you haven't been able to make like too much change when you were the medical director of sustainability, but how do you understand the landscape of hospitals in the US and, just the range of like the amount of sustainability measures they'll have, or like even offering positions like the one you helped create?
Yeah, I think I was like the 30th medical director for sustainability in the country when I got hired. And now that number is probably over 100. And I'm part of an organization called Practice Green Health, which is part of an organization called Healthcare Without Harm, that focuses on healthcare sustainability. And I would say there are leaders like places like Boston Medical Center and Providence that are way further down the road than we are, and have invested leaders. There's a hospital in New Jersey called Hackensack that just does amazing work. And I think most of that comes from hospital executives being committed to the rationale for why you would want to do this. And when you have that top-down leadership support, and you have bottoms-up people like me that are pushing for change, then you could really achieve a lot more. And I would say we did achieve several things that I think are very positive and have reduced St. Luke's emissions and also save the system money. But just the amount of work it takes to get those things accomplished just felt like it wasn't worth it at this time in my life. So I think, you look at a place like Kaiser Permanente in California, which became the first carbon net zero healthcare system in the world. UC Davis, which just built an all electric hospital. Providence, which has amazing sustainability data and tracking, and probably the best database for following sustainable metrics in the world. Boston Medical Center has like solar all over their campus, and provides solar credits for low income patients so that they can continue to get power even if they can't afford their power bills. Um, there are just tons of examples of healthcare systems that are really driving this. Um, and then a lot of systems that are sort of waiting for some regulator to tell them they have to do it, before they're going to jump into the mix. But I think what we've seen in business is if you wait for someone to tell you have to do it from regulation, then you're behind the game. And that's the message I've tried to convey to healthcare leaders. It's like, get involved now while you can design your program and do the things that you are comfortable with doing instead of waiting for someone to come in and tell you you have to do it. Because, we've seen carbon regulation in other industries, and it's going to come in healthcare at some point in time. Probably not under the current administration, but 2028 is only 2 years away.
So the Providence Hospital you mentioned, is that a hospital network, or I'm trying to find it. I know there's one in Mobile, Alabama, or
It's all across the Pacific Northwest. So it's a huge healthcare organization, that's like Washington, Oregon, California, Montana, Alaska. Um,
Okay, gotcha. And then what are some examples of things that St. Luke's, or I think you dived into this a little bit before, but just ways that hospitals can reduce their climate footprint as well?
so, I think some of the tried and true methods, that we have seen hospital systems do, and we have done at St. Luke's, are to eliminate certain medications that have a high carbon footprint without adding any clinical benefit. And anesthesia has a lot of drugs that are anesthetic gases, which are big greenhouse gases or ozone depleting chemical compounds. So there's one called desflurane that has a huge carbon footprint, but is no better clinically than a drug called sevoflurane. And Providence was the first healthcare system to get rid of desflurane and switch to sevoflurane. And it was also much cheaper at the time. So they demonstrated that you could, maintain the same quality of patient care, reduce costs, and reduce your carbon footprint. And we met with some of the people that made that happen, met with our anesthesia department, building services, and supply chain people, and were able to get rid of desflurane from our formulary. And that alone saved a ton of money, like $175,000 a year, but also reduced our carbon footprint by a ton. And then other drugs that are like that are things like nitrous oxide, which is another anesthetic gas that building developers made these reservoirs in the basement where you store nitrous, and then these big piping systems through the hospital to deliver the nitrous to the sites where you actually use it. And people have found that the delivery systems, because of the chemical compounds that nitrous oxide is, are very difficult to not have leakage of the nitrous oxide, to the tune where some systems were reporting more than 90% of the nitrous oxide was lost in the piping. So, you're just wasting money having these big tanks in the basement and these big long piping systems. So we have switched to using smaller canisters at the anesthesia machine that don't have that big piping network to lose the nitrous. And so we've saved cost, and we have reduced the emission of nitrous into the system, which, is a big ozone depleting medication and also has a big carbon footprint. And then there are simple things like switching your lighting from compact fluorescent lighting to LED lighting. Saves a ton of money and reduces your energy usage by a lot. So projects at some of our smaller hospitals had like a 6-month return on investment in terms of reducing your energy bills to the cost of switching to the LED bulbs. Um, like I talked about before, there are like operating rooms have very strict temperature and humidity control requirements. But we have several outpatient surgical centers that run their ORs at those same parameters, which is like really cold and not have any humidity, which is a hard combination to achieve and requires a lot of energy to get there. So if you run it like that 24/7, 365, and you're only operating 4 days a week, you're just wasting a ton of money. So we're looking at formalizing a program where we say, okay, this surgical center stops operating at 5 o'clock every day. At 6 o'clock, we'll turn the temperature down, or we'll normalize the temperature so we're not using so much energy to control it. And then we'll turn it back on a few hours before the surgical center starts to operate in the morning, so we know it's going to be ready for the first patient to come in. But there's so many things you can look at. Food waste is a huge problem. The carbon footprint of feeding patients unhealthy foods like hamburgers and French fries is much more than the carbon footprint associated with a plant-based diet, which is better for our patients. So we've tried to institute a policy where we're using a plant-forward diet, especially for our cardiac and stroke patients, and teach them how to do the same thing at home, so that they're eating a lower carbon and healthier diet while they're in our care, and then hopefully taking that home with them. And we've like started recycling, we've started composting our food waste from the administration buildings. And those things make a difference, but they're the thing everybody talks about doing. And I think the benefit is pretty low, and the work that goes into it is pretty high. So, I probably had 50 meetings about getting recycling into our doctor's lounge. And like it diverts a little bit of waste from the waste stream. If we could stop having plastic packaging around all the stuff we bring in, that would be a lot more of an impact than trying to recycle the plastic water bottles that you're drinking.
That's very true. I know earlier when you were talking about nitrous oxide, was it oxide, right?
Mhm.
Being delivered via piping. So that's the basement of where?
So like any hospital or surgical center will have these big tanks of nitrous sitting in the basement, and then a piping system that delivers them to the operating room or to labor and delivery or places in the hospital that use the drug. But you can do it just as easily with little tanks that are right at the bedside, and just have a little pipe.
Right, gotcha. I'm like taking notes. If
Right.
you notice, that's fine. Okay, so I wanted to transition to talking about your experience as an attending physician at an academic emergency department, working with med students, interns, residents at the largest hospital in New Mexico, and just talk about your experience. And then also it ranks pretty highly in terms of their like rural medicine program, very diverse. And you were there from 2008 to 2017. So also just looking at how the med school changed over that decade, and just working with students and seeing like how med school and residency programs, et cetera, have become like super competitive, and how that is affecting students as well. And like the lack of like work-life balance that comes with all of that.
Well, I think it's harder to have a good work-life balance in academics because you have your clinical responsibilities plus your academic responsibilities, which, like there's very much a publish or perish relationship where you have to like publish a certain amount of research documents over X amount of time to maintain your position. And so, the extra stuff that gets added into it, in addition to the fact that most academic positions pay less than a community hospital pays, make it difficult to maintain a career there. But I will say the practice of medicine in an academic hospital for me is so much more enjoyable than anything I've done before or since, where you're just like in this, very positive teaching environment. You've got people that are interested in engage working with you, opportunities to, um, like if you have you watched The Pit? Oh, you should totally watch The Pit. So it's at a teaching hospital in Pittsburgh, and really kind of shows a lot of the dynamics you see between attending physicians and residents and interns and students and nurses, and it's like this team sport that you're playing in, and you get to be like the captain of the team, and you can kind of set the tone for how the day is going to go for everybody. So I just loved being able to kind of float in and out of all these different patient encounters and help people figure out how to take care of patients better every day. So it was really a very enjoyable job, but also one that comes with a lot of stress. And um, yeah, and that's ultimately what led me to leave. Was it just was too much outside pressure to be able to do the stuff I wanted to do at home.
That's fair. Um,
So you got to make sacrifices sometimes in life, and I sacrificed kind of a job that I really love, or a job that I like. Um, I think of it as going from like a career to going to a job. Like a career is something you strive for, that you build your life around, and a job is just something you do. And that's not to say I don't love being a community ER doctor. I just don't love it with the same passion that I love academics.
that's fair. Were there ever times that you would talk to your students and like just seeing how they dealt with stress or, really heavy schedules and how that affected them? Or, if people on staff were struggling, how that would affect their encounters with patients?
Oh yeah, I mean you can't bring your home life into your patient encounters, and it's harder to do that if you're really struggling. And so I think medicine has gotten a lot better since I went through training about having work hour restrictions that programs actually follow. So, people, both the attendings and the students, aren't working like crazy hours and staying in the hospital for 24 hours straight anymore. Um, so I think it's gotten a lot better. Um, and I think people have, uh, just like in the rest of life, people have gotten more comfortable talking about mental wellness and acknowledge that it's as important as physical wellness, in your ability to do your job. And um, both being able to bring up those issues when you're at work as a student or an attending, and being met with kindness instead of condemnation. Um, like I think that helps a lot. So yeah, definitely it happens where somebody is not doing well, and I think it's the way to approach that is with openness, kindness, and trying to figure out a resolution that benefits everybody. Because making somebody keep coming to work that's suffering and miserable is only going to lead to a bad outcome. Um, so you got to like take care of yourself first before you can do your job well.
So another question I have um, is relating to work-life balance for you specifically as an ER doc, and you know possibly working night shifts and having a more intense schedule at times, and how you're able to balance that like with family life, hobbies, and then your nonprofit work.
So the easiest solution is to work less and make less money. So don't develop expensive habits that you need a lot of money to support. One of my attendings told me the worst thing you can do when you get your first job is to buy a house you can't afford or buy a car you can't afford, because then you get into this money chasing pattern where like, well, I got to pay my mortgage and I only have to work one more shift to really be able to afford that nicer car. And then I only have to work one more shift to be able to afford that nicer house. And then you end up with all these things that are adding a shift every month. And those shifts never go away because it's not like your mortgage is for 30 years. So, I think you have to figure out your comfort level and live within your means, and allow yourself to work uh, less than full time, um, so that you have space in your life for family and outside interests.
So, how many hours a week do you typically work now?
So, full time in our group is 15 shifts a month, and I'm doing between 10 and 12 shifts a month.
Okay. And has it decreased over the past few years?
It goes up and down, but not by much. When we were in New Mexico, I really had my schedule kind of figured out where I could have sort of alternating work with my wife, who's also a physician, so that when she was at work, I'd be at home, and when I was at work, she'd be at home. And so somebody was always there with the kids, and somebody was always there in that kind of at-home parent role, doing carpool and making dinner, and doing those kind of things, without it having to be the person who was at work. That's been harder to accomplish here. Um, and so my wife also works part-time, and between the two of us, we can cover everything for the most part.
That's fair. And then going back to your time at Emory School of Medicine, how's that experience like? I know you went to med school before. Taking a or two gap years has pretty much become the norm for pretty much people, especially the ones I talked to at UGA. So just like your thoughts on taking a gap year before grad or med school, why you didn't pursue it, and then just some advice for the listeners, because I do know some people that are listening are, friends that are like intending on going to grad school or med school, and then, just how to approach if taking a gap year is right for you.
Yeah, I mean, I think it's a very individual decision. And, I think if I had gone back after I started med school, I would have taken a year off, um, because like med school is super intense, right? And you have to be in like ready to go. Um, and uh, I was kind of on the fence about whether I was ready to go. And if you're not like sure you're ready for it, then maybe give yourself some time. Because like once you're in that pipeline, I mean, you're studying like super intense for 2 years straight. And then you've got 2 years of clinical rotations, and then you go straight into residency. And then you get done and you've got a huge loan that you got to start paying off. So like you're going to go straight into work. um, so if you're not like 100% ready for it, I would definitely consider taking a gap year. But some people come out of college and they're like, college was great. I feel great. I'm ready to take the next step and take it. Um, but you just got to be at a spot in your life where you're ready to be kind of sucked into, the very fast, intense period of med school and post med school training. And then the
That's
sad reality is you're going to come out of that program with a ton of debt. And like I said, it's just hard to your loans start accruing interest when you get done with residency training. So like it's hard to take a gap year after residency, and it's even harder to do it once you start med school. There's not really a pathway to be like, I'm going to take the next 6 months off and then come back to med school. Can't really do that. Or between med school and residency, you can't really take time off. Um,
Um, 1 sec. Mm, y- Yeah, I was gonna say, I feel like I just because of the rate of like medical education that, I think on my website I said that every couple months medical information doubles. In 1950, that was every 50 years. So at a certain point, do you think like 4 years is not going to be enough, or with AI and like other health tech, it's going to kind of balance out um, how much rote memorization you're going to have to do, or like information you're just going to have to absorb in school?
I mean,
And then
it's already not enough time for understanding the human body, and but that's what residency and fellowship are for, and that's what your career is. My grandfather used to always joke with me that doctors never work; they just practice. Um, because you said it's like the practice of medicine. But it's true. Like there is no certainty in the medical field. I think people on the outside, especially people with very limited medical knowledge, think that we know all the answers about everything that we're experiencing. But the reality is, most people that have some kind of symptom don't end up with a diagnosis because we just don't know what's causing your problem, but it's probably not something bad. And because we can identify a lot of bad things. And, I think the practice of medicine is a continuous learning environment where if you don't continue to read research articles and follow medical education, like you're going to practice incorrectly within 5 years. So, we all have continuing medical education pathways and um, things you have to do to maintain certification in medicine that are designed to help you stay up to date with the most current practice. 'Cause
that's
There's
for sure.
there's no there's no way you could. I mean, you would just never graduate from school if your goal was to be 100% ready to practice medicine the day you left med school. You would just be in school forever.
Yeah, and there's other fields like that, like technology, health care generally. I mean, well, there's always things that are going to be changing, and
Mhm.
you're just gonna have to, keep reading up and stuff. So the joke that I make is, if you combine all three, then you'll really never get bored. Um, so that's what makes me excited about the programs that I intend on pursuing. But it was great having you on. This was episode 2 of the Regulated Pulse podcast, and got some great insights from Dr. Ethan Sims. And till next time. All right, bye.
Thank you, Priya.
Yeah, for sure.